look at those areas where they could really make a difference, and it fell out into the areas of optimizing the AV interval and to some degree the V-to-V interval, unchanged device settings, people having the device put in out of the box and none of the parameters changed, but if carefully optimized, it did make a difference. And in some patients, the need to go back invasively and reposition the left ventricular lead. So I think if you keep these things in mind as you do your CRT troubleshooting, look at the non-responder, it makes these challenging cases a bit easier in some patients. The other thing, and I don't have the citation because this would mainly be textbook, it's been in several texts, and I could refer you back to ours, mine and Paul Friedman's, but there's a chapter by...
So this is the slide I showed earlier, a VT at about 210 per minute. This is actually the profile. He was a CV surgeon that implanted most of our pacemakers and defibrillators. And then he walked into one of our colleagues' offices saying he didn't feel quite right. And in retrospect, probably was in ventricular tachycardia for about 12 hours before coming for that. So he had this walk-in VT. Our approach, as I mentioned earlier, is with cases like this to take them, first of all, to the cath lab and just try and see what it takes as a baseline in terms of inducibility. So here you can see we're pacing single extra, induces his tachycardia. Sorry, the mouse is a bit squeaky. Single extra induces a morphology tachycardia, so we know what it takes to induce the tachycardia. Here, for those of you that probably not familiar with the CARTO system, it really is very attractive. This is an accelerated representation where you're collecting points by just moving around point by point in the chamber of interest, and very rapidly you get the anatomical reconstruction of that shell as well as the electrical features that you can include. This is actually an atrium. The latest version is the CARTO 3, which we started using just less than a year ago, and this is really quite addictive. You just swirl around the catheter. It could be a lasso catheter or something. Again, this isn't left atrium, but very rapidly you can get an extremely accurate reconstruction of the shell that you're looking at, and that's shown in the next slide. So this is the kind of picture that you can get, reconstruction of the left atrium and the veins, which is approaching the kind of details that you get on a CT scan. So this is, I think, useful advances in terms of catheter mapping and electroanatomic mapping. Moving on to what is the substrate. We mentioned the chronic infarct. This is from Andy Witt's work, but lots of other people shown. So the normal situation, of course, is before an infarct, the myocardium acts as a volume conductor, syncytium. When you do get infarction, you had surviving strands that get separated by scar tissue and lose their side-to-side connection. The end result is really to get the separation and isolation of individual tracts, so then you really get a maze kind of zigzag conduction. And that's what this leads to is the ability to identify these late potentials even in sinus rhythm, and certainly with ventricular pacing, and a lot of the people that do have a substrate and a history of ventricular tachycardia. And this is from the group at Westmead in Australia, showing that these late potentials you can actually pick up on signal averaging techniques that sort of indicate this kind of substrate. This is from John Miller's work too, showing the old Pennsylvania peel, where again here's in sinus rhythm. You get these late potentials that we particularly find the target of interest. They do the resection, those potentials disappear. They put the resected area back on, you get attenuation of the systolic electrograms, but of course you disconnected the late systolic scars that were resected, so that doesn't come back. So this is basically the histological underpinning of these late potentials. This is the same process really that happens in ARVD. Marty showed these beautiful epsilon waves in ARVD, and here's the same thing. So in ARVD, you also get programmed cell death, apoptosis with separation of myocardial fibers and tracts, and manifestations of these separated and delayed activated tracts are the epsilon waves. So it's very similar to the ischemic cardiomyopathy. Back to our surgeon who's now in the cath lab. We've shown we can induce this tachycardia. So the way we do it, and it tends to be a low-stress thing, certainly less stressful in doing the mapping and ablation than it is doing pulmonary vein isolation, at least I find. And what do we look for? So we're pacing here, and what we're looking for is on very high gain. Here's our ablation signals here. Looking for these little guys here, the late potentials. You can see some of them can be as late as 384 milliseconds past the stimulus mark. And I think these are potentially part of a reentrant circuit of ventricular tachycardia. So this is the kind of thing we knew from the morphology where to focus on, and the fact that they had an old inferior infarct. This is the kind of reconstruction. We get a posterior view of the left ventricle. These are all the scarred areas. Here's the electrograms. We also do pacing from sites where we did record these electrograms. You get this huge latency. You see a pacing spike and a huge delay before emergence of the surface electrogram, suggesting you're sitting on a tract within the scar that has the ability to conduct out into the surrounding normal myocardium. And so we tag these areas that are points of interest. We'll look at the morphology to see if there's any similarity to the tachycardia. Here, there's all selected number of areas. And then we go ahead and sort of ablate those and just take them out of the equation completely. Here's the third sort of presentation that we talked about, the sort of very slow ventricular tachycardia that we see more and more often now in people who are on amiodarone beta blockers and defibrillators. So this is the kind of thing, but very symptomatic. So this is a 71-year-old man, had an infarct at the age of 41, sort of an old inferior infarct, refractory recurrent ventricular tachycardia at 105 per minute, frequent ATPs, recurrent shocks. Logs of his defibrillator show here an example, sort of see barely above 600 milliseconds the VT cycle. Here's the atria, burst pacing, ramp, nothing really works fine, it gets a shock. And this happened just over and over again. Here's his logs in 2005, the number of therapies, and then after ablation, nothing. And here's the kind of thing, because his ventricular tachycardia was so slow, we actually mapped him during VT. This is a voltage map, and then you'll see next should be an activation map through the left ventricle. So this is the slow area, anterior view of the left ventricle during VT. And you can see there'll be slow conduction coming back through this posterior scarred area, breaking out there, coming around, and then zigzagging through here to break out again in the next beat. So ablations in this area of the return path sort of ended up in a good outcome. So what about VT therapy and outcomes? So increasingly this focus, and I think that somebody raised a question this morning about at what point should you consider doing VT ablation in patients that have a defibrillator after one shock, two shocks or more. So in the first instance, Vivek Reddy sort of has a New England Journal publication showing that certainly ablations can, over a period of some months up to 2 years, reduce the number of therapies from the defibrillator. And the other important thing, increasingly, I guess, from the SCUDF and other evidence, is that shocks, the number of shocks, and even inappropriate shocks basically increase the risk of death. So you can see out here that gradually, the more shocks you have, there is evidence now building up a case that this leads to an increased mortality. So this makes a more and more compelling case, perhaps, to intervene earlier. So our shocks are associated with increased mortality, quite apart from the fact that the quality of life is diminished in these people. So as I said, our approach is to do the substrate, and in contrast, a lot of people think there's kind of a terror of doing a VT ablation, because a lot of them are actually done during VT, people with already impaired left ventricular function. And of course, when you induce VT, these are very tedious mapping procedures that take a long time. So there's a high likelihood of patients ending up in shock during the end of the procedure. If, by contrast, you really do the approaches during ventricular pacing, it's a very relaxed procedure that you can sort of take lots of time to identify potentially areas of interest and then take them out of the equation. And when you're done, you go back in and again repeat an induction to see what you have, whether you remove it. And with that kind of approach, these are our kind of results, that we have 75% success acutely after one procedure. And the encouraging thing is, of the ones that are refractory, if you go back in for a second time, about half of those people will become responders, and the ones that you still have to go even for a third time, you can recruit some of those, at least convert them to be responders.